Common clinical indicators of subarachnoid hemorrhage include a sudden onset severe headache, often described as a thunderclap headache, as well as headache accompanied by vomiting, confusion, or focal neurological deficits. The most common cause of SAH is the rupture of a berry, saccular, aneurysm. The second most frequent cause is an arteriovenous malformation, AVM. The initial diagnostic step in evaluating a suspected subarachnoid hemorrhage is a non-contrast head CT scan, which may have a classic finding called the crab sign. If clinical suspicion remains high and the CT scan is negative, a lumbar puncture should be performed to look for xanthochromia. In the management phase, a CTA should be obtained to localize the source. Early management focuses on stabilizing the patient and preventing rebleeding and complications. It is important to control the blood pressure with something like labetalol, with the systolic goal of between 140 to 160 millimeters of mercury. Use nimodipine to prevent vasospasm. Sometimes an anti-nausea med is given to prevent increased intracranial pressure that occurs with vomiting. Remember to elevate the bed, consult neurosurgery, and admit to ICU. Subarachnoid hemorrhage is bleeding between brain parenchyma. A major complication of SAH is the risk of rebleeding, which is highest within the first 14 days, particularly in the initial 72 hours. Prompt diagnosis and early neurosurgical or endovascular intervention are critical to minimize this risk.